pauses here and there. So I'll start, because we'll go, about an hour here, and just interrupt me, come off of mute, or just write something in the chat. But the first one I was going to go over, and I think our next time that we'll meet in a couple of weeks, we'll go over a full comprehensive echo. And really, I have a couple of full echoes that we can just kind of walk through that has, pretty much like everything. And I think that's really important. But, for you guys, it's all repetition. So you want to, get in the lab, right? Get in the echo lab and try to do some echoes, and you'll find out it's not as easy as just putting the transducer down. Talking to Mansour as well, we have an echo simulator. Actually, I brought it back now. It's in my office in Gengris, but you could simulate transthoracic, but also TEE. So once we start doing some TEEs, I think it'd be really helpful to do like a rotation with you guys. To use the transesophageal feature on the simulator, because that is a really, really good three-dimensional anatomic image of the heart while with the transducer. So it kind of really helps your mind think of where you are. So we can do that together too. But I'll start off with, so today, wall motion. Kind of like Mansour said, a lot of times you're going to come in and they want you to look for wall motion. So some of the things that I have here are going to be from the ASC guidelines. So back, I think this was 2015, they came out with the chamber quantification updates. And really, that's a great resource for everything. All of our echo guidelines and standards come from the American Society of Echo. If you're not a member, all of the guidelines are free. It's asecho.org, so asecho.org. So today, this is for the wall motion part. So ideally, we'd be able to recognize the views, evaluate wall motion. Especially when you guys go in, that there's a potential that patient is going to be going right to the cath lab, right? So it's important to correlate with coronary artery distribution. And even looking at the EKG, if you see that there's some changes in the inferior leads, then you're looking for the inferior wall. Different ways that we can assess wall motion a little bit here, and then also just go over a couple of cases. So, there's different ways that we can evaluate wall motion, and there's the visual assessment. We can also do other quantitative, which I'm not really going to dive into a lot, but we can do other quantitative measures like strain. We can look at the volumes with 3D. Do they have an infarct or is it ischemia? And, sometimes we'll see wall motion abnormalities in the absence of coronary disease. You guys know what would be, what do we call that? If someone has wall motion, particularly let's say the apex is out and they do not have coronary disease. It's a certain syndrome or cardiomyopathy. I don't know why that's skipping a little. So it's, so stress-induced Takotsubo cardiomyopathy. I'll actually show you a case of that. But sometimes they look like this, right? So you guys get called in to do a stat. It's not going to be a 20-year-old who weighs 150 pounds that can turn on, his or her side, and, you have really good images. They may look like this. They may be supine. They may be vented. It's not always going to be ideal. When you see an image like this, there's no way to really evaluate a lot of the walls here. You can't see this lateral wall at all. What we use a lot in the echo lab is, we use ultrasound enhancing agents. If it's, we have Definity here, or there's Optison or Lumison, but essentially, those really, really help us with seeing walls. But it's important to, to get used to changing everything. I always tell the fellows and the students, when you put the transducer down, just look everywhere, right? It's not going to be textbook, the exact intercostal space on the left side. It's not going to be exactly where you think it is on every single person. So just make big movements and look at the screen to see when it starts, when it comes in a little brighter, and that tells you that you have a better window. One of the things that we use, especially for apicals, which is extremely important when looking for apical wall motion abnormalities, is you want to make sure you're not foreshortened. You want to make sure you're on axis. And by that, the way that we can kind of check that is in the 4-chamber view, the RV apex should be lower, the insertion of the RV apex should be lower than the, here, I'm going to use the laser pointer just so it, RV apex should insert lower than the LV apex. Anatomically, the RV apex is actually higher than the LV. So when you see them at the same exact spot, it makes the LV and the RV makes the heart look like a basketball, a little rounder. So that's how you know you're foreshortened. And, you know, that's important because you could completely miss the apical cap. You could miss the apical segment. So, you know, when you're looking for wall motion, that's going to be extremely important. But again, you know, you may be limited due to the patient's position. I tell the students there's always 3 things that you should try to change. And if you do all 3 of those things and the image still doesn't look great, then you know you did everything you could. And give them this analogy, peanut butter and jelly. We can always remember PB and J, right? Peanut butter and jelly. So P, the P would stand for patient position. So you try to turn the patient towards you if you can. B is breathing. So a lot of times breathing makes a huge difference. We have them take a breath in or breath out, and essentially the air in the lungs is either getting in the way or getting out of the way. And the last one, because I had to try to make it, you know, the J out of jelly, I use, you know, adjust your window. Basically, just go everywhere. You may have an apical window that's in somebody's armpit, you know, but if you don't go there and you struggle like hell just on that one image and you're hugging in between the ribs, and then, you know, a sonographer comes over and in like a half a second they get a beautiful apical window, and what did they? Maybe they just went a little more medial. Maybe they went a little more lateral. That comes with time, obviously, of course, and that's why it's important to scan as much as you can. But let's go over. So you guys know some of these main views, right? This is you should definitely by now. We have the long axis, which is essentially the apical 3-chamber, just with the apical segment. Right? We have the parasternal short axis view, the 4-chamber, and the 2-chamber. These are your walls. So I kind of give the acronym, if you can remember. So here's the 4, the 2, and the long, or you know we could call it the 3-chamber. So if you use the acronym infant, right? Like I have a 3-week-old baby. She is an infant. And you remember that from left to right. So if we look at this 4-chamber view, we have the inferior septum, and in the, on the other side, we have the anterolateral. So infant for inferior, lat, ANT for anterior lateral. This 2-chamber is the true inferior, the true anterior wall, and then as we get to the apical 3-chamber, we have the inferolateral and the anteroseptal. So if you look at it, you know, I know I said infant, so the first word is either inferior or it's anterior. And then if you just think the other 2 words on the 4-chamber and the 3-chamber is going to be septum or lateral. And you should be able to tease out, even if you don't memorize it, you know, this is the septum because this is the part that's near the RV. So if this is the inferior septum, that means this is our anterolateral wall. Some people may just call this the lateral. Some people call this the posterior, but this is should be our inferolateral. Then, of course, if we you know, look at our coronary distribution, depending on their dominance, but essentially, you know, this 2-chamber view is really, really important because we see our true inferior and our true anterior wall, especially with patients with bundle branch blocks. This is, we're not going to talk about stress echo, but this is a huge view. This is a very important view because this is the only view that's not influenced with the septum. So we really like this view when we do stress echo. But you can see the coronary distribution, right? Inferior, we have the RCA, and then obviously the apical segments and the anterior segments are going to be your LAD and circumflex in the lateral or the infralateral. So here's the parasternal long, and you know, you guys see this, right? So when we look in this view, we're seeing the anterior septum. Here, this is an older slide, so it says posterior, but this is my inferolateral. And this is your first look, right? Because if this wall doesn't look like it's thickening, then, you know, that's our first sign that, hey, maybe, you know, maybe there could be an LAD problem when we look at that first wall, when we look at this anterior septum. Again, maybe it's RCA or something. We see this inferolateral wall. So if you look at these two views and you suspect wall motion, you want to see it in another view. So you really want to, you know, ideally see this in another apical view. So, you know, where do we see this parasternal long is the same exact thing as the apical 3, the apical long axis. So you definitely want to see it there, but the advantage is we can actually see the apex. Well, we're not really going to see the apex in this view. Here's our short axis view. And if you think of, you know, kind of use the acronym SALI, S-A-L-I. So here, just to make it easier, here's the, let me do this because it'll show up. Here's the apical segment. So if you start here at the septum, so S for septum, A for anterior, L for lateral, I for inferior, right? So left to right, going around the circle, going clockwise, SALI, septal, anterior, lateral, inferior. It's always good. You get a million things to memorize, so it's always good to try to get some type of an acronym. You know, this we can tell I'm at the papillary muscle level, right? So we can see our papillary muscles here. We can see the heart thickening, and, you know, I kind of put the laser pointer right in the center here, and we'll look to see, you know, all walls here kind of squeezing towards the middle. Just be careful. If you see this and it looks normal, that doesn't mean there isn't wall motion, right? So this is just cutting the heart this is right at the pap, so it's like the mid portion of the ventricle. So you could then go down to the apical segment here, and it could be completely out, right? So unless you're really seeing all the way down to the apex in this short axis view, just be careful that this view isn't really showing us all the wall motion. It's a nice thing to cross-reference, but really we have to look in the apicals, or we have to look, you know, all the way down at the apical segment when we do our short axis view. And then here's our apical 4, right? Remember, infant, and then which one is the septum? So it looks like, you know, I can see the RV on our side here, right? So this is the septum. So this is inferior septum, and then this on the other side, infant, so anterior lateral. The other word would be lateral. So I'm not sure why it's doing that a little bit. I keep having to click on it. But a lot of times, just because of the physics of how the pulse, you know, our sound waves are sent, we very seldom see perfectly this whole lateral wall. And that's a big deal, right? Because you could be missing an entire coronary distribution, and you kind of get this fake out like, oh, here's the wall. I see this wall thickening. You don't see anything, and, you know, in this image we don't see anything over here. So, you know, at first glance it looks like this is overall pretty well, but, you know, who knows what's going on in this base to mid anterolateral wall? You know, especially if you're doing this whole echo for somebody with a wall motion. Again, you guys, when we do like the comprehensive echo, maybe I'll go deep into other things, but here's our mitral valve, right? Here's our left atrium, right atrium, tricuspid. Here's our right ventricle. So then what we do is we counterclockwise about 90 degrees, and then we bring in the 2-chamber. So here, infant. So you don't have to worry about septal or lateral. So this on the left is our inferior wall. This on the right is our anterior wall. And we basically just break those up into segments, right? So the basal inferior, mid-inferior, and then apical inferior. Same thing on the other side. And sometimes you can actually see it here, little dog-eared shape outpouch right here, and that's the left atrial appendage that we can see. And then the last one, you know, here's our apical 3. So, you know, we see remember infant, so inferolateral wall here, and then on the right side we have the anterior septum. So it's just, if you just took this, and if you just, rotated this image counterclockwise, this is your parasternal long. It's your parasternal long, but we can see the apex. We don't, typically we're not going to see the apex in a parasternal long axis view. This is out of the guidelines, kind of a nice little, diagram. What about, seeing wall motion? I think it's one of the hardest things to really be comfortable or to master, right? So it takes experience. I mean, that's all it is. It takes experience, and you want to see them. It can be, like I said, limited image quality. You could be foreshortened, the patient position, their window, their body habitus. If you're doing somebody who's post-op open heart surgery, you're going to have surgical dressings, and it's going to be really tough to, you might even have a drain in, and it's right where the apical window is. So it's, a lot of times you could be restricted. What do you guys? I don't know why this is. So do you see a wall motion here? What part of the heart do you think is not squeezing?
So, Steve, can you hear us?
I can now, yeah.
Yeah, so Justice has a few comments.
I just said this patient has a definitive deficiency. The apex does not look like it's moving, but we cannot see it at all. We don't see the endomyocardium. So it looks like someone with an apical hypokinesis, including the inferior septum and the anterior lateral wall. But it's not a complete study because we don't see that clearly. I would want to get definitive.
Yeah, absolutely, right. You can see the base coming in, and we lose, like you said, we kind of lose the image there, but you're certainly suspicious. You kind of see like a hinge point where it's coming. And the other thing is if you use contrast in a patient like this, which you would every time if the apex is out, you also want to make sure that there isn't an apical thrombus, right? And there's some techniques we do for that, but really important to see if there's an apical thrombus or not. Yeah, so let's, then here's, just to show an example, here's an echo. So here's a 4-chamber view. What do you guys think of the wall? Any wall motion on here, or does it look pretty good?
I can take a shot. It's not the best image, but overall, based on this picture, it's maybe also foreshortened, which will give us maybe a false impression about the wall motion. But this picture, if you just had to judge based on it, it looks it's moving okay. Yeah, I'm pretty, and these are the images you guys are going to get. But now look at more lateral. So if we move more lateral, this is it looks like a completely different heart, doesn't it? Not even just the clarity, but what do you think of this? So actually, this part is squeezing well. But the apex.
But what's going on up here?
So apical aneurysm?
Yeah, and so the other thing, so differential diagnosis, it could be an aneurysm. Looking at this, you would think pseudoaneurysm, right? Because the neck is very narrow. But what would be a differential diagnosis besides an aneurysm? Could be a certain type of cardiomyopathy that we see this in.
Huckum.
Yeah,
specifically apical hypertrophic cardiomyopathy. So this was someone with apical. So they had echoes in the past, and they called the EF normal, and no mention of anything else. And then kind of like lucky to get this on-axis window. What happens with these apical hypertrophs is they develop these little diverticulums or outpouches, and they basically can get really, really big, where it's like a big apical aneurysm. But you can actually see the other thing, I didn't show it on here, but what happens is they get these early peaking diastolic Doppler signals going from the apex to the base of the heart, which is opposite when we think of obstruction. You think of like hokum, we see late peaking, kind of like a daggered shape. And what happens is this is completely obliterating right here. So in systole, the heart squeezes and some blood gets stuck up top. And then when the heart relaxes, when it opens up this little this little canal, I guess here, then all the blood shoots down. And that's usually when we see that, that's a sign, that's a tell that there's probably going to be an outpouch or an apical aneurysm with those apical hypertrophy patients. Yamagata, yep, Yamagata Takasubo. So for that, Yamagata is another name for apical hypertrophy. Yep. Yeah, we always think, to be honest, probably the last like 50 apical hypertrophic patients I've seen, and we see it more with, I guess we see it more because we're using image enhancing agents, but they probably all have been like, middle to older white women for some reason. We always thought it was like a Japanese variant, but we see them in all sorts of things. I think we're just actually seeing them more now because we're seeing the apex better. Okay, yes, yeah, how's it going? Yep. So let's move on. So here's a 39-year-old guy. So this was actually an echo I did a couple of years ago. They ordered a stat. I think what was the story? So they had an abnormal EKG, and the guy had some chest pain. They gave the patient nitro, and the ST changes kind of went away, and the chest pain went away, but then it came back. So, essentially they were looking, this is a young guy, we're looking to see if there's wall motion. So I'll show you the image. Like, do you guys see any wall motion? These aren't bad images, but, does any wall motion jump out to you guys here?
Oh, sorry, go ahead.
Yeah, someone said aortic root, question the aortic root. Well, here's the aortic root here, I guess, if you're wondering what's going on. Over here is a lot of haze.
Yeah, it's
I wouldn't.
Haze. I don't know if I can make something. I thought it looks a little bigger.
A little big, is that what you're saying?
Yeah, Steve. I don't.
Yeah, it could be. We measure. So whenever you think of one of these guys is a centimeter. So if we look at here, we're probably just like 3 centimeters or so here, or maybe a little bit. Yeah, we want to get a higher window and look at the ascending for sure. But just to focus on wall motion, is it possible underneath, these cords in the papillary muscle, you don't really see it well. But, I don't think it would be able to say that there's an infralateral wall motion here. Definitely the septum looks well, right? Like it looks like the anterior septum is squeezing well. We look at the short axis and, it looks pretty good. It looks like it's thickening. Again, these are only 2 views. So let's look at the apicals. So here's our 4-chamber, our 2-chamber, and a 3-chamber. So I saw these views, and a wall motion kind of jumped out to me. I don't know, do you guys see it? Where do you guys think there's a wall motion?
I think anterior lateral.
Yeah, so is it possible on this second beat, you kind of get when you get away from the papillary muscle, we get maybe a little hint that there's some, that there's some hypokinesis underneath there. The anterior wall here, we just can't see. And then in this 4-chamber view, and again, this lateral wall, you could see a 4-chamber view that looks like this in 100 patients, and they're all not going to have wall motion. A lot of times we just kind of lose this portion of the lateral wall. But, maybe I could buy that there is something going on there. What about the apex? Is the apex thickening, or do you think it's out?
Again, the definition of epic is not very clear, so we just have to assume, there is something going on. It's kind of tough to really say that there's definite apical thing, but I think if we have some definity, it would help us clear up a little bit more. It's quite hazy at the apex, but I see it now that, we know there is something going on, so really focusing on the apex does seem like it could be funny.
Yep. Yeah, and I remember, I don't know who was there. One of the fellows, we were in the room in the ER, and I was kind of, I was trying to sell that there's this lateral wall motion, and we're like, and we could even talk about, you guys, at least at St. Francis, because we have the Definity in the fridge, and you know, at some point, if you wanted to, there's no reason why you guys wouldn't be able to take a Definity with you and be able to use it. So if that was something down the line that we wanted to be able to do, I could just do like a quick training or something. But I really think it could help you, especially in those wall motion, you know, in those wall motion cases. So let's look. Oh, that's an older picture. One of them was probably like 5 years old. So where's the wall motion? We kind of talked about it. So we did use, you know, we did use contrast. And here, you know, the apex is thickening fine, right? But if we look, definitely this mid to, you know, almost distal portion of that lateral wall,
Yep,
is not for sure, right? Like now you look at this and, you know, you ask 100 people in a row, they're all going to see that wall motion. And then again, the same thing with this inferolateral wall. Not only can we see it's there, but we can really see the full extent. You have to be careful looking. So when we look, see all these speckles in the muscle, in the myocardium, and we see them up by the apex, right? So we actually see perfusion. So we're actually seeing microperfusion there when we use contrast. There's different presets and things like that you have to do, and you have to be careful. But, you know, you look here, and it looks pretty black. You could be fooled sometimes, right? But here we see speckles. Here we don't. So, you know, it probably means that we aren't getting perfusion to that portion of the muscle. They went and did a cath, and these are just still images. Still images of it. It looks like they had some Ds in the RCA and also in the circumflex. So that was a 39-year-old guy, and he ended up going on to have cabbage, believe it or not. So he was a young guy. He was a young guy, and he definitely had some disease. Let's see. We won't go over this as much. This is strain. Actually, this is strain on that same person. We have much better quantifications now, and actually, very soon it should be updated. But we'll have strain on all of the reading computers. Strain in 3D, QLab. You guys will be able to go in, and the way it works now, it could be any two-dimensional image, and you can go in and it has the Tomtec version. It's called Auto Strain. We can go in and just quantify strain, which would be a different kind. Here talking about myocardial contrast echo, so that's perfusion. And essentially, sometimes if you see, let's look at, if I showed an example, you know, you might see some of the sonographers do this, probably not so much, but we were playing with it a little bit. And essentially what we do is you're going to see a very loud flash. And what that is, you see there's two numbers up here. There is 0.18 for the MI, that's our power, and then 1.3, and see how it says F? That's the flash power. So we actually do a really, really high power flash, which bursts the bubbles, and we look to see how quickly they replenish. And, you know, we can do perfusion. You know, we can do perfusion, and there are studies out there where they actually do this, you know, flash, and they, on STEMI, patients come in, and they actually have shown some good success with potentially breaking down the plaque and things like that in the arteries. It'll be interesting where we are in a couple of years with contrast echo and things like that. But so you'll notice here, this is the right ventricle, and this is somebody unfortunately who's had cancer, and we have a big tumor here in the right ventricle, and this is not a clot, because a clot wouldn't have vascularization. So you can see very bright enhanced here. We do a flash. You see initially it's very black, and then within like a beat or two on this one, it actually replenished right away. So look, you see the flash, it's black for a second, and then it replenishes right away. It's almost the same brightness as the myocardium. So that's essentially how we are supposed to determine perfusion. I don't want to go through that as much here. Do you guys have a question?
No, Steve, I have a quick comment, because one of the fellows here is asking me, this was like the bubbles burst. There's a trial actually done in Brazil, 2019 or 2018, few hundred patients. They did this perfusion, like high mechanical index and bursting the bubble wire, they're transferring STEMI patients to the emergency department. So they randomized patients to this high mechanical index or just nothing in standard of care. It was a feasibility trial. What they found is that those people who had the burst had better EKGs and less infarct size based on MRI and slightly higher ejection fraction. So it's a promising kind of technology. Maybe it's going to be used in a few years. Who knows? But I just wanted to add this. I will send you guys the trials to Steve, Ursula, and all the fellows to look at it. It was a fascinating concept.
Yeah, no, and they're even, they're using, it's crazy. You look at some of the different talks other places, and they're using it to deliver treatment too. They can actually focus and they can activate a bubble right exactly where there is, where there is a tumor. So that's a separate trial, but it's crazy the different things that we may be able to do with just contrast echo. I think that one was the one you're talking about. Was it in Brazil or something? I forgot where you said it was.
The trial was done in Brazil, I think in Sao Paulo. The lead investigator actually is from the U.S. He's from the University of Oklahoma. And I think the reason they did it in Brazil is just because it was doable, the FDA regulation and things like that. But yeah. I think there is more and more acceptance to this technology, and there is more ongoing trials. I will email you all the trials after this talk to look at it.
Cool. Yeah, and at some point down the line too, Mansoor, I could do just like a contrast talk or something, and we can kind of focus in on that.
That would be great.
There's a lot to talk about with that.
Yes.
So here, I'll show you, here's another case. So this is a 63-year-old lady who came in, had some back surgery, presented with shortness of breath, chest pain, some weakness, showed some new T-wave inversions in her lateral leads. So she was admitted and, to evaluate for suspected non-STEMI. But really, I just want to, so if you guys look at this image, right? So is there a wall motion? This is the first image that you put the transducer down.
Apical.
Yeah, look, we kind of have, it's kind of like the base of the heart is thickening here, but this whole rest of the heart, especially we look at the septum, it's not thickening, right? And sometimes you could take, like here, I put the little pointer, and you can see how there's motion past the pointer, but then when I go here, it's just kind of stuck in the same spot. So definitely, I'm not going to be surprised if the apex is completely out. Now here's a short axis view, and you'll see, so this is a sweep. So I'm basically starting at the mitral valve level almost. And then, so you'll see some motion, right? And then as I go to the mid-ventricle and then all the way down to the apex, there's no thickening. And that's because, just kind of to show, we look at one view. That doesn't mean that the heart is perfectly normal. Thickening, you have to look at the others. Here's our apicals. So again, kind of lose things. Is there a thrombus in the apex? Is there not? But it looks like the base of the heart is really just thickening, and the rest of the heart is not. They use contrast, and we don't have to go over, but to see, sometimes we do a faster injection to really rule out a thrombus. But was kind of the reason why I added this case too is I did perfusion. And if you notice, sometimes you can just be careful with the lateral wall, or if you're looking at perfusion. But this whole area is not thickening, right? So this whole apex, mid to distal portion of the inferior septal, it's not thickening at all. But there is a lot of speckles. So essentially, once you do that flash, in real time, it's hard to interpret. But what you could do is you could tease it out, and you can actually there's a bunch of different ways that we can do this. But essentially, if you look here, and we'll just focus on one area right here. So very speckly, a lot of perfusion. Then we do the flash, right? Here's our QR, so we're seeing the beat. Right after the flash, it's black. And then within one beat, within 2 beats after that, 2 or 3 beats, it's completely reperfused. So, who needs a cath, right? We got, for this one, we could say that there's, so this,
obviously I'm kidding, but there is, there's a role. It's kind of interesting with perfusion. So this patient actually had completely normal coronaries, and this was, this would be Takasubos, right, which is a pot. This is how they catch octopus, and that's why we call it a broken heart syndrome or any of those names there. The other thing with Takasubos is it doesn't have to just be the apex. It could be it could be opposite. The apex could be thickening very well, and the base of the heart could be out, or it could be focal. It could be just basal. There's a lot of different ways that we can see Takasubos, and I think there was, I don't know if it was here or if I was talking to someone else, maybe it was Dr. Sugang from Yale, and they had a patient who came in with COVID and then basically developed Takasubos because she was stressed out about paying for the bill, the hospital bill. So it's kind of, I don't know how much we see Takasubos in the COVID patients, but that's kind of like a quick wall motion. And then I'll just show, I'm not going to really go over this as well, but I wanted to show one more case. So when we look at this, you can actually see, there's a very bright section here in the septum. So that tells you it's probably an old segment, it's old scar tissue. So that's an old infarct when we see that. It's actually developing an artifact here. We see a comet tail artifact.
So
this patient,
hypertrophy too on the last picture, Steve.
Was that?
Was there any basal septal hypertrophy?
There, so you got to be careful because this could be thinned out because of the infarct. I have all the other images for this one afterwards. So I'll show you. It does look, it does definitely look thick. The question is, at one point, was the entire anterior septum thick, and now this portion is thinned out because of the infarct, or is it truly like a little bit of a sigmoid septum? Or if we look here, this is a centimeter, right? So that's definitely more than a centimeter. So I definitely say there's some LVH there for sure. This is, here's an example of, this was a patient a bunch of years ago, and so here's the short axis view. You guys see anything that looks weird there?
Inferior.
What's that?
I thought inferior wall.
Yeah, what is it, just akinetic, or what do you think?
Frame rate is really poor, but it looks like it's moving very, it doesn't seem like it's changing much, but it looks like it's there.
What's striking to me looking at this heart is the trabeculations more than the motion.
Yes, they get thrown. A lot of times in the short axis, we get thrown off by that. Right? Here we can, is that part of the wall? Is it just a trabeculation? So let's look at it in another view. So here is an apical view. What view is this?
Steve, this is not a unusual heart.
No.
This is kind of hybrid.
Or is it?
I don't know. There is, so I'm cheating. So Ursula is with me, and she's feeding me the answer.
Oh, that's not fair.
So there is a rupture between the LV and the RV.
So you may look at this and think that this is, so there's a rupture between the LV and the RV. So I'll tell you, we got to look at other views. Obviously, of course, this is not the RV. So this is actually a two-chamber view, believe it or not.
So this is a free wall rupture.
Yeah. So look, I'll show you the LV gram. Oh.
Wow.
Minor leak.
Minor.
So that's normal. Okay, to have big old pseudoaneurysm. So that's a pseudoaneurysm.
Yeah.
In that short axis view, when you look at it, you're like, I'm kind of confused with the trabeculations. This is actually the aneurysm. And this is two-chamber view. That's not the RV. That's actually, that's the aneurysm. Here's the neck, right? So this was unfortunately, it ended up getting like even bigger. They weren't able to operate on this patient, but it's pseudoaneurysm. Here's this other one. I was just showing you guys. You know, you can see that brightness, right? Here's our apical views. Again, very bright here. Portion of the inferior septum, inferior wall. Not the best image, but it looks like the apex is out. And, you know, you'd be surprised. Like, you look at this, and that's not a very good image. But we went and did strain, and I'm not going to go over strain. I probably should have put less images in here. But if you look at this bullseye, essentially I can see right away this area, the anterior and the anterior septum, is very low, and there's actually some positive numbers here. There's some dyskinesis at the apex. So this is classic for a big old LAD infarct. Right, very low strain numbers, and we see our base, our mid, and our distal anterior septum. So I think, you know, we definitely see more and more strain now as years go. It's going to be something that we just do on everyone. So here's the case, because this kind of goes along with the last one that I showed you. So this was a guy. This is, I don't know, does anyone know what movie this is from, this guy?
Naked. I think it's Naked Gun.
It is. Oh, geez, I don't even know what the hell. I forget his name. He is in Naked Gun, but this is actually Airplane is the name of a movie from the 80s.
Oh, okay. I thought it.
So it's the only reason I put that, because this was a guy. So this is a guy who was traveling on an airplane, and he had some chest pain. They actually landed him at Bradley. This was a Dr. White patient, I think, a couple of years, many years ago. He went to St. Francis, showed 100% circumflex lesion. He underwent stenting 4 days. So 4 days after the cath, he had, you know, some shortness of breath, and they heard a new murmur. And I think they were actually, you know, potentially going to discharge him, so they ordered an echo. And this is why, you know, sometimes you look at our limited echoes, and they're like color everything, and we're doing like, you know, there's almost 40 images or so for limited. And, you know, the reason for that is, you know, I didn't even see on the indication new systolic murmur. It just said, you know, echo for an MI. So I thought, okay, they're just looking for the wall motion, not knowing as much of the history. So here's a 4-chamber view I put color on, and that's not normal, right? So there's a lot of mitral regurgitation. Now, is this acute severe mitral regurgitation, or is this chronic?
It really depends on the LA size. You know, if you have images without color to see if LA is dilated, it looks bad.
Yeah, and it doesn't really look that big. We would do a volume or something, but this LA, you know, I can tell you, it didn't measure big. It didn't measure big. So, you know, when we see that, you can even see with the color, it basically reversing into the pulmonary vein. And we can, right, so here's our systolic reversal. There's so much MR that it's dumping off into the pulmonary vein. We have systolic reversal. So I saw that, and then I wanted to take other images. And I actually, here's our regular 4-chamber view. You know, maybe there's some lateral wall motion here. Right, guy had a circumflex. And then I started going a little bit more posteriorly, and look what I found.
Cord rupture.
Yeah, and it's kind of even caught in the cords. That's why we don't see it like flapping in the wind by the leaflets. There's a little bite out of it right there. So this is actually a rupture, and we can see it even really nice. You can see it in this view.
Flopping.
And it's, you know, not surprised he had a circumflex lesion. So, you know, which papillary muscle, if you didn't even know the lesion, which papillary muscle are we more likely to rupture post an MI?
It's a medial one, right?
The posterior medial, yeah. And do you know why?
Just because the other one has a dual supply, so this one has a sole supply for the dominant vessel. So if that is affected and it was late presentation or delayed reperfusion, they are at risk of having ischemia leading to that.
Yeah. Yeah, typically it was just the RCA supply.
Yeah.
So here's a couple other views here showing it. So, you know, obviously he didn't go home, and, you know, it ruptured.
and that's obviously a surgical emergency. So he went on, he had open heart surgery. They replaced his valve, and he did well. He did well afterwards. Here's a 3D of a bioprosthetic valve. So you might see that too. I mean, you think, because that's going to happen a couple of days after, what did it say? I forget. 40, at 48 hours, after a couple of days. Usually develops 2 to 7 days post-infarct. So you got a new murmur. You already kind of think of what you're looking for, but what's interesting about this case is without the color and not looking, looking for it, you could have missed the rupture, but kind of going off axis, you can kind of bring it in. All right, so I'll do a little bit of right heart stuff here. I don't want to get too crazy into it, but essentially you guys are going to get called in potentially for a pulmonary embolism, right? So it's all about the right heart, and it's very difficult. You may look, make the right heart look dilated based, just because of your window. So there is, again, the AC guidelines for right heart. There's a couple of other ones here when we talk about it. What is the RV? So some of that, we don't have to go through the anatomical landmarks, but we have a moderator band. Obviously, there's an inflow and an outflow, but they're not close to each other. They're very far apart. They're not. They don't have that continuity that we do with like the mitral valve and the aortic valve. Mostly, and that's why when we talk about strain and some of the systolic measurements that we do for systolic performance, we're just looking at longitudinal motion because most of the RV is longitudinal thickening. Some of the machines now, they have auto right ventricular strain measurements, so you can actually look at the speckle tracking. So where do we see, really to assess the RV size, you want to look at it in a bunch of different views, right? So right in the parasternal long, we get a glimpse of the RV. Just be careful because you're not really seeing this is kind of closer to the RV outflow. If this is huge and you can see the LV is flattened or something like that, then that's a different story. But don't just say the RV is big or normal just by this one view. RV inflow, obviously, right? We can see it in the RV inflow. We also see it in our short axis views. We see it in the LV or even at the aortic valve level. And then our apical window. So this view here, the RV-focused apical four-chamber view, that's the view where we're supposed to do all of our measurements. And if you look, remember I talked about if you're on axis or off axis, this apical 4 is on axis, right? Here's our RV apex, and it's lower on our screen than the LV. This RV focus view, we kind of go sometimes a little bit more lateral, and you might slide more towards the, towards the armpit or so to bring in more of the RV here. And then if you notice this view, so this modified, this is actually where we're supposed to measure TAPSE and tissue because we're very in line with the annulus of the RV free wall here. But notice here, look, the RV is at the same level as the LV apex. So we actually went more medial to get this view. But look at it. Look at the four-chamber, and then look at this view. Look how different the size of the RV looks, right? So if you see the RV and you're very foreshortened like this, in a normal individual, you may make it look, bigger than what it actually is. But this is challenging, right? Like you're not going to come in and it's going to be a 20-year-old who can turn on their side and follow all their breathing instructions. So you really got to struggle to look in different views and, do some of these tilts and things like that to bring in the RV. So it's not, maybe not the best example, but you can see how when we do go towards a focus view, we bring in a little bit more of the RV free wall. And it is basically just going down a little bit more lateral. These are other views where we could see the RV. So we measure the size, and this is just, the RV shape. It's kind of like a Boda bag. I didn't have it in. I don't know if you guys have like old Western movies. It's a little bag. It's like a canteen. But the shape of the RV is very, the geometrical shape is very complex. So, at a certain angle, this isn't even, at one here, and these are all on axis, right, more or less. If we catch the RV here, it looks this size. Or if we catch it a different angle here, we make it look much smaller. So really they say, you know, try to rotate the transducer until you see the maximal plane, but don't go too far when then you see the, you know, the apex, the LV apex is completely off the window. Oh, sorry about that. Let's do this. Now the one time where it actually, you can't get the RV on axis is, you know, geometrically, what happens when the RV is so big, it actually just takes over the LV apex. This is kind of an example, and you know, these are the ones you try to go to a 2-chamber and you can't even see the LV apex because it's just it's just crowding the LV. And this does happen sometimes, but in the, you know, normal, someone without a huge right ventricle, you know, you really want to try to aim to get that on-axis view so you don't overestimate the size of the RV. These are some of the measurements we do. So we measure the basal, which our numbers we use are, so the basal third, we measure this in end diastole, in the focus, RV focus view. The mid is 3.5, so anything greater than that is dilated. Longitudinal is pretty tough. You know, a lot of places in the guidelines mention just using the base and the mid. Sometimes the mid can also be a little difficult because of the trabeculations or the papillary muscles. But, you know, these are, the basal is going to be the bottom third. The mid is going to be the mid third of the ventricle. Even just, you know, even just looking at the heart, you know, the RV should be about a third the size of the LV. Hey, Liz, have some. This is just kind of a summary of the measurements. This is just out of the guidelines, so I'll go through these. These again were those numbers. Then we talk about RV function. So we can do other things. I'm not really going to go over myocardial performance index, not in great detail about strain or 3D volumes, or really even fractional area change. But a lot of the numbers you guys probably see on all of the, most of the echoes, you might see a tissue velocity and a TAPSE. And this is, so this is actually somebody with RV dysplasia. But tissue, what we do is we're basically just, it's like how we do tissue on the mitral annulus, right? So we put a pulse Doppler there. And just be a little careful because sometimes, depending on what the heart rate is and the sweep speed of the spectral Doppler signal, you know, you see this little spike here. Who knows what this little spike is? This is the S wave. What's this little spike? It's a time. It rhymes with isovolumic
Contraction.
contraction.
Yes.
Yeah, contraction time. So the reason why I said that is sometimes this is, you know, as the heart rate increases, right, we get closer to 100, sometimes this IVCT can kind of merge together with the S wave, and you may falsely measure a very high normal, what you think is an S wave, and it might actually be the, you know, the isovolumic contraction time. So to get away from that, what you can really do is just increase your sweep speed. But the number we look for that is going to be 9.5. Anything greater than 9.5 is considered to be normal. And TAPSE, so actually we're supposed to do this in like a modified 4-chamber view. And this is just it's to give us a global estimate, right? So, and we're basically, all we're looking at the motion of this annulus. We see where it says can be used routinely, but not valid with any regional wall motion. And what we essentially do is we take this, we measure the excursion from, you know, end diastole to systole, and if we have greater than 17 millimeters or 1.7 centimeters, that's considered to be normal. But you know, sometimes your window may not be as great, right? So I kind of look at this view, and it's, you know, where do I measure? Do we measure here to here? Do I measure, you know, here? Look at this one. Is it from here to here? So you really want to try to be consistent with following the line in M mode, but that's also the reason why we try to get it from that modified 4-chamber view, because, you know, sometimes you run into the RV free wall, and you're measuring the RV free wall, not necessarily the annulus. And actually, in this case, I went and I did a tissue Doppler, and I can, although it's a little fuzzy, I can nicely see. Here's IVCT, and then here's our S prime there. Oh, so that one was not okay. So that's the question. Fractional area change, so we can actually measure the area, and you know, just by this calculation, it'll give us a number. 35% is considered. This, you know, I find it sometimes if you are using image enhancing agent, sometimes it brings out the RV a little bit better. But you know, this can be really challenging, and you know, I don't know how much I always trust it to do on an every single person basis is I think a bit of a stretch. But if the image is nice, you can do it. It's just it's hard. It's really hard to visualize the RV really well. Again, I was talking about RV strain, so we can actually measure. Usually, we just measure the RV free wall. We don't measure the septum because we can get some, you know, interference with the LV septum. So we usually measure the RV free wall. Here's an example of someone with an abnormal strain of 14, and it's not playing so well. But essentially, if we were to look. You know, you basically just, you're measuring, when we talk about TAPSE and tissue, we're measuring the annulus. So, but just be careful. If the base of the heart is contracting really, really well and the whole rest of the RV is gone, but your TAPSE is normal, it doesn't mean that RV function is normal, right? You kind of have to piece it together. Again, those are our numbers. So I'll show you one case here. So this was a 59-year-old guy who came to the ER with shortness of breath, some leg pain, increasing fatigue, history of metastatic esophageal cancer. He had history of coronary disease, hypertension. During his hospitalization, he became tachycardic and he had increased shortness of breath. So they ordered an echo. So here's his 4-chamber view. Here's his parasternal lung. Now, remember, just be careful about calling RV size and things, but sometimes you can potentially see the, you know, if the RV is really thickening. But just like I said, you're more like the RV outflow here. So just be careful in calling this the right ventricle when it is kind of more of the RV outflow. But you know, you get to here, right? So remember, I said like the RV essentially should be about a third of the size of the LV. You look at this, I can fit maybe 2, maybe 3 LVs in this RV, right? So, you know, now you're thinking, okay, this is probably big. This is going to be dilated. Here's our 4-chamber view. So this is classic. So what did this guy, what did he have? What would be the next test you should order on this guy?
UTA.
Yeah, absolutely.
McConnell.
Right?
Yeah.
McConnell sign, we can see apical sparing here, blown out RV, which is, you know, consistent with a pulmonary embolism.
A quick question, Steve.
And even just looking at it, you know, this RV is basically almost the size of the LV, right? And that apical sparing is what we can see here. That's that McConnell sign.
I have a question. So,
yeah.
In acute PE in someone that does not have chronic pulmonary hypertension, would you expect the LV to be that big in relation to the LV?
Yeah, so it's a good question. So add on to that too. If someone has like severe pulmonary hypertension, you know, that's not going to be from an acute pulmonary embolism. You know, it could be a chronic reason for that. As far as the ventricle, you know, being that dilated, if it's affected the right heart, you could see it bigger than it. Now, am I on axis here? Probably not, right? And how do we know? So I may make this RV appear bigger, but look, am I really seeing the LV apex here?
No.
I don't think so, right? But that's okay in this case because it actually shows it to you, and that's why the RV is so challenging. Right? Like, I mean, they're not necessarily just looking for the size. There are some measurements, right? They do a relative ratio of the RV to the LV, and there's like a calculation. I read it in a paper somewhere. But really, your main thing is also is it affecting the heart, the right heart it affecting the function? Are they going to have to, now change treatment based on it? So it could be dilated, but here I'm over-exaggerating a little bit because I'm off axis.
Quick question, Steve,
Yeah.
and then a comment as well. Until you pointed out today, it makes intuitive sense, though it makes intuitive sense that, you have to see the true LV apex and only then you'd be really able to compare LV and RV size. I have to admit, it's easy to miss this in the middle of the night at 2 a.m. in a vented patient, and you're trying to have a look at the RV. So it's absolutely important. I mean, this RV does look big, and if there were no measurement, and if I were lazy not to measure it myself while reporting the echo, I would think and report this as enlarged. But I don't know how much, what the size would come out to, whether it's more than 4.1 or not at the base. But that's one part. The second one, I think, which happened to me while I think it was 6 months into the first year, and I had this patient. I was called again for PE, and I got the TAPSE as like 1.4, and the pulmonary arterial systolic pressure came up to, based on the TR jet velocity, came out to be like 45 or so. So now, luckily, I was able to talk to Mansoor K, and he pointed out that at the same time at 2 a.m. in the morning, I called him, and his previous echo had showed higher PA pressures and lower TAPSE. So, and in that case, when already the RV is known to have baseline dysfunction with elevated pressures, it might be difficult to make out a PE. It's a very low yield study at that point. So, so looking at the previous echo, even either before or after performing, but before making your decision as to what the RV function is, I think it's important to look at the previous echo. I think luckily I had the back of the third year then, so I was able to not make a wrong call, but it's something important to keep in mind, I think.
Yeah, it's a great point. So your first part, you're not going to be measuring it to say, is this like mild, moderate, or and that's okay if you don't see the big take home is, I think we'd all agree that this looks big, and it also looks like the function is down, and we can see this. So very seldom are we perfectly on axis and we see the true apex, right? And that's okay. That's okay. But my main thing was, don't potentially just call the RV big on just one image, right? If you, let's say, for whatever reason, maybe not in this example, but let's say the RV looked big in the parasternal long, but every other window that I looked at the RV, it looked perfectly normal in size. Then you got to be careful. You don't want to just say, hey, it's big. It's big because I saw it in that one window. You kind of have to go through all of the images. And to your other point too, with the function, yeah, I mean, if the RV is already dilated and the function was already down, then what are you really comparing? But not even when we talk about RV size as well, not just looking at the report, but actually looking at the images, right? Because let's say this guy had an echo done before and they called the RV dilated, and I look at the report and it says dilated, and now I'm looking at my echo and the RV looks dilated. Well, I don't know. Are they in the same window? Are they in a slightly different window? So then when you, which is great in ProSolve, right? Like you can bring them up side by side and you look at it and you're like, well, you know what? That's the same. Or, you know what? Wow, this is a similar window and the RV looks like twice the size of what it was last time. It's not an easy thing, and it's a hard task for you guys. Luckily you have other senior fellows to ask, and you can look at the, the priors and things like that. But it's hard. I went to the ER, and someone showed me even just TAPSE, right? That's not an end all, and there's some people that don't even really like TAPSE. But this was years ago. I went to the emergency room, and one of the residents was measuring TAPSE, and I was doing the echo on the patient. They said, "Oh yeah, I already measured the TAPSE, and it was normal." And it was like an RV like this. And I'm thinking, well, what the, where did they measure? And I asked them to show me, and they were measuring. They were basically, what were they measuring? They were measuring the septum, the interventricular septum by M mode, and that was the TAPSE. So what you see in a report may not exactly reflect what you guys might interpret. So I think it's, as a general rule, if you're able to look at images, it's extremely impactful. If you can, right? But
Yes.
Steve, I know you have a meeting in less than 10 minutes, so it's up to you. We can take this during the next conference. We can continue tomorrow at 7:30. We have a dedicated RV talk with Dr. Chen, so we'll take.
Okay, that's great. Yeah, so I don't even. Yeah, we'll maybe we'll just do the effusion. We'll get through the effusion part, and then I can add on the comprehensive echo when we do it next time.
Okay.
Okay. All right. Well, all right, guys. Thanks. I'll see you. I guess it's in a couple of weeks. We'll do the same thing again, and hopefully see some of you guys in the echo lab too.
Fantastic,
Absolutely.
Steve. Thank you very much.
Thank you, Steve. Great.
Thank you. And I'll see you sometime soon too, Ursula. Goodbye, Ursula. Is she there?
All right. I'll let her know. She just stepped out.
All right. Take care, guys.
Thank you.
Because